Now in this video, we'll see what is the difference between a static image and a fluoroscopic image. Because the fluoroscopy has a lot of advantages and more information compared to static image. So Dr. Venkateswarlu will explain to us what is the difference between this conventional or static versus a fluoroscopic image of HSG. Yes, sir.
Yeah, and now just we'll take an example here. See, this was taken in a conventional X-ray HSG or non-fluoroscopic HSG. If you see the image, they take 4 images. So one is a plain image to know what are any densities in the bowel that interfere with the uterus opacification. So the first is plain pelvic X-ray, and they take another 3 X-rays, what is called spot films. There are 4. Okay. 4 images. So you have a radiation of 4 X-rays. But when we do under fluoroscopy, we check any problem in the pelvis. Just a few seconds, fluoro will know what is any abnormality, any radiopaque densities in the pelvis. So we reduce the radiation. That way, one way of radiation reduced. Here, this procedure is a blind procedure. You inject some medicine, that is a contrast media, and take spots. You are not seeing how the contrast is entering the uterus, how the contrast is coming out through the fallopian tubes, opacifying, and coming out. So that's why in this case we can see it is what we are seeing a little bit opacification of the uterus in these films, and tubes are not visible clearly. So it is called suboptimal hysterosalpingogram. So when you do the same thing, when it was done, when patient came to us, it was done with the other 2 images under fluoroscopy. Nicely you can see few seconds fluoroscopy and contrast injection showed normal uterus, normal fallopian tubes, and good opaque peritoneal spill. So that is the advantage of a fluoroscopy, because you are visualizing the flow of contrast as how the contrast enters the uterus, the tubes, and into the peritoneum. So that is the main advantage of fluoroscopy. And if there is any tubal block, we can immediately open it. So fluoroscopy is a must for a HSG or tubal candidates.
So in a simplified way, you can say that if you look at a photo, that means we see what it is that person. If you see a movie, we see actually what's happening, how everything's movement is seen. Similarly, so that this is a static image where we don't know, it's a blind procedure. We don't know what we are dealing with. But whereas in fluoroscopy, we get the real time, how the contrast is going inside, opacifying the uterus, showing the tubes, whether patent or not, everything is seen. So always, fluoroscopy always should be done. So though cost is slightly more, we should not go and get it done under a normal conventional X-ray. We should always do it under fluoroscopy. That is the advantage of fluoroscopy over the conventional HSG.
Now you can see this just demo images. You can see now a catheter is passed into the uterine cavity and they injected. Now you can see there is a blue thing coming out of tubes. You can see the video clip, how it is.
So this is a real-time procedure. We can see the opacification of the uterus and the tubes. You can see the uterus, the tubes, and the spill in the peritoneal cavity. That shows that this test is normal. So we can, few seconds, we can tell whether it's abnormal or normal. So it is very easy way to do it.
And we can see there is a normal HSG. You can see the uterus and the fallopian tubes. Each fallopian tube length may vary from 8 to 13 centimeters and a diameter of 0.1 to 1 millimeter. Basically, HSG is demonstrating the lumen. It's called a luminogram. So we don't know what is happening outside. That's why there is a limitation of the HSCs. We are not assessing the outside of the uterine fallopian tube. There is one limitation. And again, when the tubes are blocked, so now we can see in this images in the first okay. Now we can see in this the catheter is in the uterine cavity, and already the diagnosis was done. There is a block in the this generally, I mean, why it is so successful? Because 90% of tubal block, that's a column block, it can be treated. Only the 10% of tubes are abnormal. So it is very good. So earlier we used to think tuberculosis is very common and infections are very common. See, when you say column block is there, most of the tubes may be blocked. But fortunately, with my experience of maybe around 80,000 cases and 15 to 20,000 cannulations, is a good news is most of the times it may be amorphous debris which is causing the block. Just simply put a wire and push it, it goes into peritoneal cavity, the tube is open. So now we can see the contrast is coming outside into the peritoneal cavity. Next. Okay. Now we can see how the patient comes with the infertility. Now this HSC is done, and we can see now this is a normal uterus. You are not seeing any tubes. So it's called a proximal tubal block or column block. So this is the place only where the role of our interventional technique of catheterization and these are three words are used: fallopian tube catheterization, fallopian tube cannulation, and there is another word FTR. So the another word is recannulation. And but unfortunately, because we are not aware what is happening to the tube beyond the cornal region, that's why I use the term evaluation. That's all, because we don't know whether the tube is normal or abnormal and where is the problem. So I use the word evaluation of the fallopian tube. That's the word I use for all these things. So now we can see now the tube is selectively cannulated into the cornal region. A wire is passed through the tube, and when you just see, the tube is absolutely normal and the free peritoneal is so when there is a cornal block, we know various causes of cornal blocks. But what I expect is 90% of times we are lucky, we can open up the tubes and rest of the tube will be normal. And the other side, you can see this is a normal tube and free peritoneal as well. So this is a procedure. It should be done at the same time of the hysterosalpingogram. And if there is a tubal block, I mean, you open it up. So the advantage of this procedure. Next.
So before going to discussing each entities, what is going to say, in summary, it's very simple thing. We do both static and fluoroscopy. Basically, when we give contrast into the uterus, it opacifies the uterine cavity. And from the cavity, it goes into tubes and goes into peritoneal cavities. That means if the tubes and everything is visualized, that means this lady can conceive without any abnormality in the test. So the thing is, always visualization of the uterus, tubes and spillage, the three components which are important while doing the procedure, which he will explain to us in a diagrammatic way. But there are some cases where some blocks, that's why he used the word evaluation. That means study of the uterus, tubes and the spillage into the abdominal cavity. So that he is going to explain to us now where the problems can be and how it is to be handled with. Now, the further cases we'll see now.
One more advantage of fluoroscopy HSG. So in this case, this was done as a routine. We can see now this is a tenaculum holding the cervix, with the cannula they use. The injected contrast, what you are seeing is, you are seeing the part of the uterus and you are not seeing any tubes. You are seeing instead of that, some contrast filling into those are called veins, that is called intravasation. So they are entering into the veins of the uterus. They are not opacifying the tube. So this is a blind procedure, you don't know, because when you inject with a force, it goes into the fallopian tubes, into the veins. So this is called intravasation of the contrast. So now you don't know what exactly the status of the tubes.
So how often we see, sir, this kind of, I won't say complication, it is just
this is a procedural problem. And sometimes when there is a tubal block, when you increase the pressure in the uterine cavity, the contrast goes into the vessels, veins. So it's called intravasation. And also other thing is sometimes they go into the lymphatics. So lymphatic intravasation. So these are the two terms we use. So in this case, so these are all suboptimal histosalpingograms which are done under X-rays without fluoroscopy. Then this patient came and again we did just repeated in a few days after that. This is done under fluoroscopy. Again, here also you are seeing the intravasation. So sometimes a small tubal uterine pressure also gives rise to intravasation. So in this immediately we just stop injecting and next. And now we can see, now we cannulate the tubes. So here in HSC done under non-fluoroscopy, you don't know what is the status of the tubes. Here what you have done, on the right side, we just passed the wire and we injected the contrast. So it is a tube is still occluded. So it is a tubal occlusion. So earlier what I call is a tubal block. This is a tubal occlusion. On the left side, when you cannulated, tube is normal with a free space. So this is the advantage of doing a procedure in a fluoroscopy and tubal cannulation. At the same time, we can diagnose and treat. Next.
So in a single sitting, both we are evaluating these tubes, diagnose the problem, and put a small cannula into it and catheter and dilate it so that the contrast goes into the peritoneal cavity. So it's a both diagnostic as well as therapeutic way of doing things. So in a single sitting, we are doing both the things. That's what the advantage of fluoroscopy over the static X-ray conventional HSG.
Yeah. The pain, generally we are always thinking counseling plays a very important role in reducing pain during the procedure. So before procedure, if you counsel the patient properly, and the pain perception is very less.